welcome to another great episode of On Call with Dr. Randy. I have Dr. Stephen Bradley with me. He's an anesthesiologist, podcaster, musician, military man. Anything else I'm missing? Are you great at playing spades?
No. You covered it all. I can't tell my secrets. I don't know how to play spades.
All right, we're going to teach you one day. Just don't renege. That's all you need to know. Just don't renege and you'll be all right. So welcome to the podcast.
Hey, appreciate you having me on here, man.
Great. So I wanted to have Dr. Bradley on to discuss the wonderful world of anesthesia. So it's a lot of people kind of been hitting me up about surgeries they have coming up and what they need to do to prepare for those surgeries. So I want to start off with just anesthesia. People have heard of this specialty, but don't necessarily know all the time what it all encompasses. So what is an anesthesiologist? Give us a rundown.
Man, it's such an important conversation to have because a lot of times what I notice is people are so concerned about surgery, which is normal, right? Somebody's going to cut you open and you're so concerned about the surgery you're going to have that you don't really think about the anesthesia portion until the day of when you're sitting in the pre-op holding area. So as an anesthesiologist, your anesthesiologist is a medical doctor. There's studies that people don't really know that anesthesiologists are physicians, first of all. Anesthesiologists are physicians. We've completed 4 years of medical school, and then we've completed a 4-year residency program in anesthesiology. Sometimes we also complete an additional year of fellowship training. Some of the fellowships are pediatric anesthesia, cardiothoracic anesthesia, doing open heart surgeries and really complex stuff. You can do an extra year specializing in obstetric anesthesia, regional anesthesia, which you're doing nerve blocks mostly, critical care medicine. You can work as an intensive care physician or even a chronic pain specialist. But my job as an anesthesiologist, what I tell my patients, is to keep you safe and comfortable during your surgical procedure. And we use a number of different modalities. The reason our training is 4 years is because we need to know how to perform and to plan the best anesthetic for each person that we come into contact with. We take a look at your medical problems, your comorbidities is a word we use, anything that's going on with your heart, your high blood pressure, if you smoke, if you have gastroesophageal reflux, have you had problems with anesthesia in the past? We take all of those issues that you're coming to us with, we look at the type of surgery you're having, and then we help you make an informed decision about what is the best way to keep you safe and comfortable during that procedure. We develop a plan. We're working either by ourselves. Sometimes we're working in a care team model with nurse anesthetists or anesthesiologist assistants or resident physicians. If so, we discuss that plan with them. Then we take you to the operating room and keep you safe and comfortable during that procedure.
Okay. So you kind of talked about all the different fellowships that anesthesiologists can go to. What do they learn in each one of those special fellowships that kind of sets them apart?
Yeah. So during our residency training, we spend several months in the subspecialty areas. So during residency, I actually did about 6 months working in an intensive care unit. There's times that I'm the only physician on call in the unit overnight. We're rounding on patients, developing plans for critically ill patients. I spent 2 months in the chronic pain clinic where I'm seeing patients that are suffering from chronic pain, doing procedures under X-ray guidance where we're doing nerve injections, epidural steroid injections, developing plans for management of complex pain phenomena that patients may have. Pediatrics, during that year, yes, as a resident, I did 2 months of pediatric anesthesia. As a fellow, you spend a whole year doing pediatric anesthesia. You'll learn how to take care of the sickest kids, kids that are born with developmental or congenital heart defects that are having heart surgery. And you become really good at those tiny little humans. You're trying to place IVs in tiny little veins. You're trying to place breathing devices in tiny little airways. And you also spend some time in the pediatric ICUs, learning how to care for complex ill children. For cardiac anesthesia, that's an extra year fellowship. We do 2 to 3 months of cardiac anesthesia during residency, but again, fellowship is a year where you're spending 11 or 12 months doing open heart surgeries. You're doing ECMO cases, which is extracorporeal membrane oxygenation Oxygenate.
You there? Oxygenation. I
There
got
we go. There we go. I swear my degrees are real, but
you.
you're learning how to manage these super sick patients, putting these big cannulas or tubes in them so that they can go on a bypass machine. You're learning how to run a transesophageal echo probe where we insert an echo device. It's like a small tube that goes down the throat and has an ultrasound machine that looks at the heart in real time during surgery. We can look at the blood flow going through your heart. We can look at how the valves of the heart are working. We work hand in hand with the surgeon. If they're replacing your mitral valve, for example, and we're saying, hey, this looks pretty good, might be still a leak, and you can tighten that valve up a little more. Obstetric anesthesia, again, another year of training where you're working with high risk OB patients. We know that, childbirth can be a very dangerous time. It's a very happy, joyful time, but there is such a thing as high risk obstetrics. And for women that are at increased risk of having heart failure during pregnancy or need additional care, you can have that extra year of training to be able to take care of all of these patients. I am actually going to go back and do a critical care fellowship. Again, I did 6 months during residency, but this is a whole year working in ICUs where I learn and board certified to be an intensive care physician. I think I covered most of them. There's a regional fellowship, which I did regional anesthesia throughout residency as well, where we're doing nerve blocks for procedures for pain control afterwards. A regional fellowship gives you an entire year to become proficient at that.
Okay, all right. That was a lot of good information. I know sometimes we as physicians on the other side, we don't know all that encompasses anesthesiologists and the different fellowships. My friend Lauren, she did a cardiac fellowship, completed that a couple of years ago. What's making you go do the critical care?
Yeah, so I went to Howard University, College of Medicine, and I remember being a medical student. I was the first person in my family to go into medicine, and I didn't know what I wanted to go into. I thought I wanted to become an orthopedic surgeon. I get to medical school, I meet the other, orthopedic surgeon wannabes, and I was like, oof, the vibe and personality was not me. It's something you had to really invest in and get started early on. And I was kind of lost, honestly, for the first 2 years. I just didn't know what was going to be right for me. And I had a buddy that kind of put me on to anesthesia. But before I really set my sights on anesthesia, I was working in the ICU on my general surgery rotation. We would round on patients in the ICU. If they were, we would have a census of maybe 12 patients, and maybe 3 or 4 of them would be in the ICU. And I would start to deliberately pick up those patients. I have this weird thing that I do where if there's something I don't particularly like, I'm not particularly fond of, I will teach myself to like that thing, whatever it is. And everybody hated taking care of the ICU patients. They were very complicated. You had to do a really long progress note and presentation. And I said, you know what? I'm going to figure this out. I'm going to crack the code and really enjoy this. And I did. I learned to love those critically ill patients, the physiology that I'm learning and reading about and discussing. And Dr. Saram, this old Indian dude, like the Yoda of the ICU. He had this old scrub, his taco meat would just be hanging out, and he'd stand there on rounds and stroke his chest and just pimp you incessantly, just go on and on with it. And he knew everything. And I'm like, yo, one day I'm gonna be like Dr. Saram. I want to have medical students that look like me, that don't look like me, that just look at me as this person that knows so much and can break down this information very simply. And that's what I wanted to do. Because I joined the military out of residency, I was unable to complete the fellowship directly after finishing residency in 2018. So I'm concluding 4 years of service on active duty this summer and returning to complete fellowship.
Okay. All right. So that explains it all. And for those who don't know, pimping is asking questions. It's not literally having Dr. Bradley out there on the stroll trying to get money for him and for the hospital. So we got to make
sure these student loans.
Yeah. So we got to make sure that everybody know what he means by pimping him while he's out there on the rounds. So let's talk about patients and what they need to do to prepare for surgery for you specifically that helps you out.
Yeah, the biggest thing that patients can do is just take care of themselves. I know it sounds very simple and vague. I'll get more specific, but we want you walking, exercising, being in the best shape you could possibly be. That'll help keep you away from surgeons, away from hospitals, away from anesthesiologists. Don't stay away from family practice doctors because you need to see them.
Come and see me.
So, yeah,
Get
we
your
need you
yearly
seeing.
physical.
Yeah, if you're yearly physical, you need to see Dr. Randy because that'll keep you from having to see a bunch of other people that you don't want to see. But to get more specific, there's a number of reasons that people have surgery, whether your knees are worn out and you need to get those replaced, whether your coronary artery disease has gotten bad enough to where you're having chest pain and you need an open heart surgery, whether you're coming to the hospital to deliver a baby, whether through a vaginal delivery or cesarean delivery, a number of different reasons. One of the biggest things that we need to do to keep you safe and comfortable for your procedure is make sure that you haven't eaten anything within a certain amount of time. The American Society of Anesthesiologists has very clear guidelines for preoperative fasting. Basically, we want your stomach empty because we're going to give you some sedation, we're going to give you sleeping medication, we're going to get you off to sleep. And when that happens, the sphincters, the kind of valves on the tube of your esophagus and stomach, they get relaxed. If you just had a Big Mac and you come see us, we put you to sleep, there's a large chance that Big Mac is going to come up your throat and you no longer have that gag or that cough reflex. Whereas if you're awake, you shove your finger in your throat, it's going to gag and cough. And that's a protective airway reflex because your vocal cords are slamming shut and that's keeping food, liquid, all that from getting into your vocal cords. When I induce anesthesia, you fall asleep and you no longer have that reflex. So that Big Mac's going to come up and they can find its way into your lungs, which is a terrible prognosis. It can lead to a long hospital stay and even death. So there's specific hours for when you can't eat. For most healthy people, 8 hours from a solid meal. And you can have clear liquids, which are like tea, which are coffee without cream, because cream has fat in it. It's one thing that it slowly empties from the stomach. You can have water, you can have Gatorade up to 2 hours before your surgery. Those are one of the biggest things that folks come into. We're going to ask you, hey, did you eat? Because if you ate that morning, we're going to have to significantly delay or cancel your surgery. The 5 things that I teach my residents to quickly preoperatively evaluate a patient. Now, mind you, we've probably, especially if you're at a teaching hospital, we've probably looked up your medical history beforehand. I'll usually look up my patients the night before, or half hour, 45 minutes before surgery if it's a bread and butter, pretty straightforward procedure. Otherwise, I'll meet you the morning of. I'm going to ask you, when is the last time you ate or drank anything? If you've checked that box, I'm going to ask, have you had any problems with anesthesia? Have you or anybody in your family ever had any problems with anesthesia? There's a very rare condition called malignant hyperthermia. And that is when you are allergic to some of the medications that we use in anesthesia, specifically neuromuscular blockade or anesthetic gas. Very dangerous procedure or very dangerous allergy and very, very, very rare, but one of the worst things that we worry about happening in anesthesia. There's a way to safely prepare for that. We just have to clean out our machines from all the anesthetic gas. We usually schedule you as the first case because the anesthesia gas can kind of hang around. That can trigger an event. So I'm going to ask, hey, have you ever had any problems with anesthesia? And usually people say, well, I'm slow to wake up or my blood pressure gets low, and that's cool. I could take care of that. But if they say, oh, well, my uncle died on the table or had a reaction, we're going to start asking some more questions and determine, are you at risk for malignant hyperthermia?
What can happen to someone when they have malignant hyperthermia?
Yeah, so the first thing we notice when you get exposed, and the weird thing is you can actually have anesthesia a couple of times and not react. And then all of a sudden, you have this predisposition to malignant hyperthermia. You're going to be exposed to the anesthesia gas or to the medication succinylcholine, and your body starts to overheat. It affects your metabolism on a cellular level to where your body's just continuously in on mode. It's a hypermetabolic state. You start to heat up. Your muscles get very rigid. you start to have a fever, and then you start to have a hemodynamic collapse. There's medications that we can use to reverse that, but it's a very significant condition that we want to avoid.
So I'm gonna go into patient mode because I'm gonna do you like how they do me. So you're telling me that this can happen to me, and I've had surgery before and nothing wrong has happened to me. How can I prevent this, or what do I need to do beforehand to make sure that this doesn't happen to me, Dr. Bradley? That's my Southern
Yeah.
country.
So if you don't have any history of this happening in you or your family, then it's a good chance that you're safe. That said, we always take precautions. Every hospital that's accredited will have a malignant hyperthermia cart that is immediately available. Your anesthesiologists, we're trained to immediately recognize the signs and symptoms of a malignant hyperthermia presenting in a patient. And when that happens, we're calling our colleagues for help. They're dragging this whole, it's usually a refrigerator on wheels. They're grabbing it, running to the operating room, and we're giving you the antidote. There's a medication that reverses the effects. We're going to get that to you as soon as possible. If there's a risk, any kind of risk that you may have malignant hyperthermia, we're going to do a non-triggering anesthetic. We'll probably schedule you as the first case of the day to decrease the amount of anesthetic gas you're exposed to. We take the vaporizers off the anesthesia machine. We use a total IV anesthetic and avoid giving you any of those medications.
Okay, all right. So that's good information. So what's the third thing that you were naming on the list?
The third thing is going to be any allergies to medications. Always important to know, is there something that we cannot give you or that you're concerned about? We get a lot of things that are actually not allergies. There's a difference between an allergy and an intolerance. So like, oh, fentanyl, which is one of the opioids we use to treat pain, makes my stomach hurt or makes me nauseated. That is an intolerance. It's not quite an allergy, but I'm not going to have that discussion with you right now. I just want to know what works for you for your pain. But a lot of times, like penicillin, it gives you hives or a rash or makes your throat close up. Like, whoa, that's a big deal. We're going to avoid that medication. I'll ask, what types of medications are you taking, and what medical problems that do you have? I know it's technically two, but it's my number 4. I just put my fingers up.
Mhm.
What medical problems do you have? And then usually patients are like, oh, I'm fine because everybody's healthy. And I follow it up with any heart problems, chest pain, history of heart attack, high blood pressure. No? Okay. Any lung problems, asthma, sleep apnea, COPD? Do you smoke cigarettes? And I just kind of go through heart, lungs, GI. So any reflux or heartburn. Those are kind of the big things that I worry about. Depending on the type of surgery, I may ask about other medical systems. Now, granted, I've already looked the patient up. I've already looked you up in the record. So I already know that you have a history of high blood pressure. I know you have these things, but I like to have that conversation with the patient. The last thing that I ask is your functional status. How far are you able to walk? If you walk up 2 flights of stairs, do you have any chest pain or shortness of breath? Can you walk 2 city blocks? Those are what are called metabolic equivalents.
Mhm.
And it talks about how much stress your body is used to tolerating. The reason that's incredibly important is because we say anesthesia is about as stressful as walking up 2 flights of stairs. So if your heart is in good enough shape that you can do that, okay, I'm not worried about anesthesia stressing you out to the point that you may have a heart attack in the operating room. Because we do take care of patients that have bad functional status, that you're bed bound, you're unable to walk, there is a way to take care of you safely. I may place an arterial line, which is a blood pressure monitor that goes into the artery in your wrist, monitors your blood pressure with every beat of your heart. And I may be very slow and gentle getting you off to sleep. So there's always ways. We train to be able to take care of all types of patients, but how we screen you and how we determine, your functional status and level of health is a very important to developing that correct anesthetic plan for you.
Okay. Okay. So those are all good tips. I hope y'all got all of that. So let's do a case example. So nothing too crazy, nothing too crazy. So let's just say I'm going to surgery. Let's say I have appendicitis. Shout out to my book, Appendicitis, on Amazon. Y'all can go figure that out and buy a copy. But what are you going to do for me to prepare me for surgery? Like you mentioned, you walking in the room, you're going to ask me all these questions, and they wheel me back to the room. What's kind of the start process from your end for me once surgery starts? I didn't eat anything for the last 8 hours,
Mm-hmm.
no past medical history, the sinus problems. I'm on some Flonase, it's controlling my sinuses. That's pretty much it. I'm in there. Oh, I got
Yeah,
this right lower quadrant pain. It's like, okay, they did my imaging and now it's time for surgery. So what is
cool.
Dr. Bradley going to do for me to prepare me for surgery?
Got you. So I got the call. We got a roughly 32, 33-year-old young man, BMI probably 19, looks
Okay.
like.
Okay, man, I'm looking
Um,
good and I'm young.
yeah.
All right.
So what I do is first go to the operating room because we got to set up our operating theater. It's a little unique to our specialty that we do a lot of things that are hands-on that other people don't. So I'm going to make sure there's an IV that's set up, and it depends on your institution that you're practicing. I'm going to make sure I have a breathing tube set up, a laryngoscope, which is the device I use to place a breathing tube. I'm going to test it, make sure the light works. I'm going to make sure I have emergency drugs available. I'm going to check my anesthesia machine. Like every time we do anesthesia for folks, we go through a systems check. We make sure we have suction available. All these things are what we ensure are in working order to do our job safely. While I'm setting this stuff up, I'm also looking up Randy in the computer. I'm checking over the labs. I'm checking his medical history, make sure that all he has is some sinus problems. Does he have EKG on this admission? Although at the age of nice young man, I'm not terribly worried about heart problems. But I'll take a peek at the EKG. Oh, does he have an echo? Well, that's weird. Why does he have an echo? Okay, well, it was normal. Maybe he was feeling short of breath. That's cool. Echo was from 6 months ago. I'll look at the echo report. Valves, everything's looking great.
Okay.
Then I go out to pre-op holding. I meet Randy. Hey man, how you doing? Dr. Bradley, anesthesiologist. I'll be taking care of you. I'll be keeping you safe and comfortable during your procedure. Personally, like me, I teach my residents. I use words that are less triggering, like surgery scares people. I say your procedure, and I'll keep you safe and comfortable.
Oh,
I'm
thank you,
going
Dr.
to.
Bradley. Thank you. Oh, I got a black doctor. Don't kill me. That's the sarcastic thing I would say before.
Yeah,
Surgery.
I've heard it all. I've heard it all.
Yeah.
I'm going to go through those questions that I answered or that I just asked. When was the last time you ate or drank anything? Are you throwing up? Any heart problems, lung problems, asthma, sleep apnea, problems with anesthesia in the past, family history problems with anesthesia? You function normally. I think I saw some videos of you hooping. So if you can play basketball, you're good to go.
Okay.
I'm going to do an airway exam. I'm going to listen to your heart and lungs, make sure I don't hear any murmurs or any problems with your lungs. I'm going to look in your mouth, have you open wide, stick out your tongue. I'm going to look at your teeth, see what's cracked or chipped, if anything is, because afterwards, I don't want Randy coming after me because he's trying to get your grill replaced when it was jacked up before you came to me. I talk about risk and benefits of anesthesia. Very important conversation where I say, the things that can happen when I place a breathing device: sore throat, hoarseness, risk of nausea, vomiting when you wake up, risk of damage to your lips, teeth, or gums when I place a breathing device, but I'll be very careful to decrease that risk. Some of the bad things that can happen are heart attack, death, and stroke. That is a risk that comes with anesthesia and surgery. But based on your medical history, you're at extremely low risk for any of those things happening. I will keep you monitored the entire time with the blood pressure cuff going off every 3 to 5 minutes, an EKG that's continuous, and I'll be monitoring your oxygen levels the entire time.
Okay.
Is it okay if we proceed and I take care of you, keep you safe and comfortable?
Okay. All right. So then you're going to inject me with some medication, correct?
Yeah. So typically you'll come up from the emergency department with an IV in place. Typically, I will start off with an anxiolytic. It just takes the edge off things. It's a benzodiazepine called midazolam or Versed, and usually 2 milligrams of that takes the edge off. It's like a beer, maybe 2 beers, depending on how much you drink. And it's an anxiolytic as well as anterograde amnestic, which prevents you from forming memories from about that point in time until the medication wears off. Some people, especially kids, it could be very traumatic going back to the operating room. For kids that are having frequent surgeries, it's kind of nice to to blunt those memories so they don't develop a phobia or a fear. Some people are chill and want to see the operating room, they don't care. And I kind of try to assess that. Like Randy, you know, he looks a little nosy. He's gonna want to see what's going on. He's gonna be looking at me crazy. So I'm gonna, you know, he's gonna be chill. He's gonna want to see what's going on. So he doesn't get any versa. He's gonna be looking around. So that's going in through the IV. We go back to the operating room. It's gonna be a little painful, little bumps on the stretcher. Get you to the operating room table, get you positioned. Your head's gonna be up on a pillow. Once we're in the operating room, I'm going to put the monitors on you before I give you any additional sleeping medication. Those are EKGs. That's the pulse oximetry, which measures your oxygen levels in your blood. I'm going to put the blood pressure cuff on and have it start squeezing. And then I'm going to put an oxygen mask on. This is part of the anesthesia machine, and you're going to breathe in 100% oxygen for ideally 3 to 5 minutes. And what that does is, you know, as humans on Earth, we're breathing in about 21% oxygen. Oxygen's mixed in with nitrogen and a bunch of other partial gases. Probably won't put you folks to sleep if you're driving. I won't talk about science too much longer. But your lungs are full of other stuff, not oxygen.
Right.
So I throw this mask on your face, and now you're breathing in pure oxygen. So once I got you laying on the table, I'm going to start giving you some more relaxing medication. I'm going to have this oxygen mask on you. So you've breathed for 5 to 7 minutes to replace all that nitrogen that was in your lungs. Now it's replaced with oxygen. The reason this is important, the next thing that's going to happen, I'm going to give you some more medication. Typically for a young, healthy person like yourself, I'm going to give you some fentanyl, probably 100 micrograms of fentanyl or so. It's going to take the edge off of your pain. It's going to decrease your respiratory rate because it's an opioid. Excuse me. And then I'm going to give you some propofol. The dose is about 2 milligrams per kilo of propofol. I'm going to inject that into your IV. People commonly refer to that as Michael Jackson juice. That is unfortunately what Michael Jackson passed away from, taking in an unsupervised state that was not properly monitored. I'm going to give you that medication, and it's going to get you off to sleep. It is a hypnotic and anesthetic, as well as a respiratory suppressant. So it's going to impair your breathing. After about 2 to 3 minutes, you're now asleep, quote unquote, and you're now apneic. The reason I filled your lungs up with air, pure oxygen rather, is because you can now remain apneic for about 5 to 7 minutes before you start to desaturate and we get into trouble. It is another safety mechanism that I have built in. In the meanwhile, I'm going to be able to ventilate you by hand. I'm going to put the mask on your face and be able to push air into your lungs. And once you're asleep, I deliver another medication that causes muscle relaxation, which helps open up the airway with my laryngoscope device. It keeps the vocal cords from moving, and I'm able to place a breathing tube into your vocal cords, secure that with an inflatable cuff that kind of seals off the windpipe and keeps secretions from getting into your lungs. And then I'm going to hook you up to a ventilator. I'm going to tape your eyes closed to decrease the risk of your eyes getting scratched or any corneal abrasions. I'm going to tape this intratracheal tube in place and then maintain you on a volatile anesthetic gas. So you're going to be breathing in anesthesia gas, and that's what keeps you asleep during the procedure. I'm going to turn you over to the surgeons. They're going to clean you up, prep you, get you ready to operate. And the whole time that you're asleep, I'm there monitoring your vital signs. Fun fact, so pain is the conscious perception of a painful stimulus. So technically, while you're asleep, you don't feel pain. What I'm looking at is the body's sympathetic response to a traumatic insult. So when you're anesthetized and asleep and the surgeon makes incision, your body is going to take that information, process it, and you're going to have increased blood pressure, increased heart rate, increased respiratory rate. That fight or flight response is what kicks in. A lot of that is blunted by anesthesia, and I titrate my anesthetic in to blunt that sympathetic response because I want to maintain homeostasis. I want to maintain you at a normal heart rate, blood pressure, everything normal, because the more you're stressed, that's putting that stress and strain on your heart. Remember I said anesthesia is about as stressful as walking 2 blocks. Well, that's what I want to maintain you at. Same heart rate, blood pressure, all that you would have if you power walked a block or 2.
That's why you can't have that sedentary lifestyle. That's exactly what I explain to my patients when I'm clearing them for surgery when they come in to see me. Do you exercise? If so,
Yeah.
how often? Do you have chest pain or shortness of breath when you exercise? Okay, you're older, you don't exercise as much. Are you doing some housework, some
Right.
yard work? Do you have stairs at home, like Dr. Bradley mentioned? Are you having any chest pain with those activities? Because surgery, as he said, is stressful. And if you're already getting stressed out by just carrying a load of laundry from one side of the house to the other, you're not going to make it safely through surgery.
Yeah. And I'll just add a caveat. That means we want to identify that early. If you're having chest pain from carrying a basket of laundry, that is anginal equivalent, means maybe that there may be something going on in your heart with a blocked blood vessel. So maybe we need to take you and get another procedure to look at the blood supply in your heart and maybe fix that before we fix an elective issue.
Right, right. So I'm sure you've heard of these stories or patients talking about when they've been put to sleep but still feel things or hear
Mhm.
things. What kind of happens in those cases?
Yeah. So awareness is one of the dreaded complications that can occur in anesthesia. Fortunately, we're pretty safe. We've really, so anesthesiologists have done tons and tons of research over the years to make anesthesia one of the safest fields in medicine, to be honest. The monitors that we have, medications that we have, it all goes into making sure you're completely anesthetized and unaware of your procedures. We're watching your heart rate, your blood pressure, all of that to make sure that your body's not responding in a way that you're going to be aware. Before I placed that breathing device, I injected a neuromuscular blockade. So that's a paralytic. I don't like to say paralytic to patients because that's a negative connotation. It's scary. Nobody wants to be paralyzed. I'll say I'll give you a muscle relaxant, or I'll give you some neuromuscular blockade. The good thing is that provides a immobile surgical field for the surgeon to operate on. This helps me ventilate as well. The worst case scenario is I've given that neuromuscular blockade and then I don't give you anesthesia. You are now paralyzed and aware. You can feel what's going on, you can hear everything, but you can't blink, you can't move, you're paralyzed and aware. Now, what would happen to your body is your blood pressure is going to go through the roof, your heart rate is going to go through the roof, you're going to start sweating, you're going to start crying. All these are signs of awareness.
Mhm.
The machine is built to alarm if your anesthetic level goes too low. And looking at all the signs, we should be able to know pretty quickly that you're at risk for awareness. Typically, it's rare to have no anesthesia on board. Your anesthesia might get a little light to where you have less than you should, and then those signs start to kick in. But the reason we train for 4 years of residency is to recognize all these signs and then ensure that we're dosing the medications appropriately up front to decrease this. Now, the bigger issue is the misconception of what awareness is. A lot of people come and say, well, I woke up during the procedure, or I felt the procedure, or I heard voices. And again, I want to validate their concerns because they're at a very vulnerable state about to have surgery. But I have to ask, what type of surgery did you have? If they had a cesarean delivery, those are typically done under an epidural where you are awake the entire time because we want you to see your beautiful child being brought into this world. If you're having a colonoscopy or EGD, where they're putting a camera down your throat or up your bottom, you're getting a deep sedation or a deep sedation, and you're not completely anesthetized. I always tell the patients before they have these colonoscopies, you may remember hearing voices, you may remember feeling pressure, you're not going completely off to sleep. That said, some people still confuse the two and may be concerned that they woke up during their colonoscopy. Sometimes we do procedures under nerve blocks, where if I put a nerve block in and you cannot feel anything in your ankle, the surgeon's going to work on your ankle. I can technically give you no anesthesia. You can lay there because your ankle is completely numb. And matter of fact, like if I had surgery on my ankle, I would get a nerve block and I would sit there and just hang out, listen to music. That's what I would do.
Mhm.
But most people don't like that. So we give you a little sedation. Now, does that mean you may remember something from surgery? Yes, you may remember voices, but the difference being if you're not paralyzed, you're going to start moving and they're like, oh, hey, yo, we got to give them some more medication. Or if you're super light, like I've told patients, like, hey, this is going to be light anesthesia. If you're uncomfortable, just let me know and I'll give you some more. And they'd be like, all right, put me to sleep, doc. And then got you, boom, I'll give you some more medication. So it is a very much a spectrum, but as long as there's not neuromuscular blockade, it's less likely going to be actual true awareness.
Okay. So since I'm still on the operating table and we're going down the
Oh, are you?
yeah,
I forgot.
I'm still there. I'm still there.
Uh-oh.
And so we're going down the road of stuff going wrong. What happens or what do you do when someone starts to crash? What is your role specifically?
Yeah. So as part of our board's process, we sit through about 2.5, 3 hours of oral board exams. We got to go down to North Carolina and they ask us questions about these cases. We have all
So
these
for those who don't know, kind of give a rundown what oral boards are, because some of my listeners may not know what that means.
Yeah. So to become a board certified anesthesiologist, we take a written board exam halfway through residency. When we finish residency, we take another written board exam. I think it's either 4 or 6 hours. And once we pass that, we can apply to an oral board exam that also has a hands-on component. Once we get our data signed, we practice. I think I practiced for about 2 months with two of my compadres. We were just going through case presentation. You have a pre-op portion, intra-op portion, and post-operative portion, and then some random grab bag questions. And you'll sit across from two board certified anesthesiologists, and they just go a 35-minute session, and then you go to a second 35-minute session. And so for these 70 minutes, they're just asking you questions about, they give you a case that you'll read beforehand, and then they'll ask, what's your plan for induction? If this goes wrong, what are you going to do? What are you going to do now? What's your plan for the airway management? And they'll just go through all these questions and scenarios that really take you across that breadth of anesthesia to ensure that you're ready to practice. You have good judgment, good clinical reasoning, good communication, good fund of knowledge, and you're adaptable. So the worst thing, probably a year ago, I had a young, healthy kid on the table for a belly surgery, and the surgeon, to get into the belly, you put a kind of a needle in, and then you insufflate. You put carbon dioxide gas that kind of blows up the abdomen and allows him to see what's going on. Well, the surgeon shoved the needle in, and his face kind of just froze in horror as he said he felt bone. He was concerned that he shoved this needle or his trocar straight back into this patient's vertebral body, which is your spine, right? If you poke hard enough into your belly, you can maybe feel it if you're a slender individual like yourself. So the big problem is there's some really big blood vessels that run in front of that vertebral body. So the surgeon, immediately understands like what this could be. So they very quickly actually finish their surgical procedure, being vague just because of patient privacy. And then they did have to open the patient's belly and ensure that there was no significant damage to the large blood vessels, the abdominal aorta, the inferior vena cava, because the patient could exsanguinate and hemorrhage. Now, for me, as anesthesiologists, we are there to provide the safety. We're always thinking about what can go wrong. So as soon as this happened, I am immediately on call, calling the blood bank. I am under the drapes, putting in a larger bore IV. I am drawing blood samples so I can get immediate type and cross down from a lab. It takes, at my institution, probably a good 50 minutes to get type and crossed blood available. So if this patient was bleeding and hemorrhaging, I needed a large IV to give volume to give crystalloid and blood products. I need to make sure that we had blood products available to give this patient. Those are the things that I would do in case of a hemorrhage. And then, it's all about a differential diagnosis. Maybe a patient's having an intraoperative MI. I'm seeing EKG lead changes. I'm communicating with the surgeon. Hey, we got to wrap this up. I'm going to start giving beta blockers. I'm going to switch to 100% oxygen, all the things that you would do to treat a myocardial infarction. We have differential diagnosis. Maybe it's a pneumothorax. Am I going to do a needle decompression? Am I going to do an ultrasound to determine, is this a pneumothorax or not? What's going on? So we have this whole differential that will very quickly develop. We're also very, we don't look at calling for help as something to be ashamed of. Anesthesiologists are very quick that, hey, if something's going wrong, this is all about the patient. We have a button in every operating room where you can have an anesthesia stat if it's like a crap's hitting the fan, and you're going to have some folks run in that room. or there's always a coordinator, at least where I work, where I can call and say, hey, I need an extra pair of hands. They're going to be there, Johnny on the spot, and be able to think and work through this together. In a care team model, it'd be a nurse anesthetist in there, or anesthesia assistant or resident. They'll call their attending or the staff anesthesiologist, and we'll be able to work and navigate through these critical scenarios safely.
Okay. All right. So I didn't crash.
Uh-oh. Okay.
How do you wake me up in this scenario? So surgery is over. The surgeon has walked out. He's left the resident in there to kind of sew me up and get me ready to basically wake up. So how do you wake me up, Dr. Bradley?
I'm just going to hit the off button.
Is that simple?
Almost. So remember, you're breathing in anesthesia gas. So the first thing I'm going to do is turn off the anesthesia gas. Depending on how much anesthesia gas it took to keep you anesthetized, it'll probably take anywhere from 8 to 15 to 20 minutes for the anesthesia gas to wear off. The whole time the gas is coming off, I'm making sure that your neuromuscular blockade, the paralytic, is worn off. We have reversal medication to make sure that there is no residual paralytic. I like to get you breathing spontaneously, and I titrate in opioids for analgesia, maybe some Toradol, other pain medications, some Tylenol, to try to maintain a comfortable respiratory rate. I use that respiratory rate as a surrogate for how uncomfortable you are. And once the stitches are done, they've got you taped up, we take the drapes down. I want to suction your airway because sometimes there's secretions that build up. I'm going to say your name, Randy. You're going to look around. And sometimes young people usually wake up fighting. You're going to be swinging on folks. So it's kind of an art to make sure that it's safe. You're going to protect your airway. You're going to breathe on your own, but you're not pissed off because it's breathing tube shoved down your throat. You're going to start fighting people. And when you're like in that nice little safety area, boop, I'm going to take the cuff down, pull the breathing tube, put the mask back on you, ensure that you're moving air and breathing on your own. And then we're going to transfer you to the bed and move you to the recovery room.
Okay. And I'm supposed to have my wisdom teeth taken out in a couple of weeks. I hope I don't wake up swinging on people, not swinging, swanging. Like, they better back up just a little bit so I don't throw them in.
Yeah, I think the biggest thing is that anxiety of people being afraid that I'm about to have pain. And that's like really scary for people, understandably so. If you know what's going on, you can get your wisdom teeth. They can just numb you up and take them bad boys out. But a lot of people don't like people working in their mouth, and they're going to probably go a little heavier on the sedation to keep you asleep.
Yeah, he asked me, do you want the laughing gas or be put to sleep? I said, put me to sleep. Just put me to sleep. Let's get it over with. So I think you provided some great information on anesthesia. I appreciate you sharing everything from your background to how to put people to sleep, possible complications, and how to wake them up. I really thank you for sharing that. Kind of as we wrap up, I always like to conclude with Randy's random questions. So are you ready, Dr. Bradley?
I'm ready as I'll ever be.
All right. So you started your own podcast, the Black Doctors Podcast. What made you start your podcast?
Back in 2020, the honest truth is I'm in the Navy. The pandemic was going wild, but my hospital was quiet because we had young, healthy people. I had some free time. I think a lot of people started hobbies during the pandemic. I was looking at social media and representation in the healthcare field. I wasn't an influencer, but I said, how can I actually make a difference and reach out and provide mentorship and guidance? And the influencers I saw didn't reflect my time in medical school residency. I struggled. And I wanted to share stories that were, in my opinion, real and relatable. And I looked at different mediums to share that with. And I was like, I'm going to figure out podcasting. And that's how the Black Doctors Podcast was born. As the name and your niche is all that is important. And I was like, we're going to call it what it is, the Black Doctors Podcast. I feel like that, is simple. It's to the point. So coming up on 2 years in June.
Okay, that's what's up. So y'all make sure y'all go listen to this podcast on all streaming platforms, the Black Doctors Podcast. Question number 2. So you're in the military. What has the military made you better at that you didn't expect?
It's a good question. The military has made me better at, I've had some early growth at my medical treatment facility. Understand that service members every 3 years were moving with different orders. I've actually stayed at my location for 4 years because I'm getting out. What that means is there's a lot of turnover. So you very quickly become one of the senior people, one of the go-tos, one of the trusted positions. And fortunately, I feel that I've lived up to that expectation. I started very early with leadership roles, running the operating rooms, making the schedule. And I think, I am happy that as a Black man, I was able to fill that role and provide that representation. Understand the military is so disproportionately, there's levels to everything. So when you're enlisted side, it's, you have a lot more young Black enlisted service members as opposed to the officer side and military medicine side. So these young kids are used to seeing leadership and anesthesiologists and medical physicians that don't look like them. So one of the highlights of my job is being able to go in and they see Dr. Bradley, Lieutenant Commander Bradley, and I want to speak to them when I see them. I'm going to give them words of advice, words of encouragement. I'm not going to treat them poorly. And they get to see me, hopefully, living in this space where I'm a competent physician, a good communicator, a good leader. So I love that I'm able to model these behaviors and hopefully impact the lives of these young Black service members for the better.
Okay, that's what's up. Thank you for your service. And last question. So you're a musician, correct?
I like to think I am.
Okay, what instruments do you play or you attempt to play?
So I am a classically trained pianist. I took lessons in high school, junior high school, and studied for a year in undergrad. I was going to be a music pastor at one point in time before paths diverged. So I play piano, read sheet music very well. I switched into pop and arranging and composing. In med school, I picked up bass guitar. So I play it with my worship team. I play keyboard or bass. I picked up acoustic guitar during residency and I started to really collect different instruments. So I have a melodica, which is kind of a cross between a harmonica and a keyboard, which my wife hates. I don't play that one too often. I have a bunch of other random like synthesizers, which is something that I was like, I really want to learn how to play these really weird analog musical instruments. Then I have an electric drum set as well. So I just enjoy being able to, what vibe am I on today? I'm going to go play this instrument, try and make it sound beautiful. Sometimes, it takes a lot of practice. It don't always sound good, but I love being able to create and express myself in that venue.
Okay, so here's the real question I want to ask you. What is the most overrated instrument and what is the most underrated instrument?
The most underrated instrument that is just really probably, they always say that the French horn is the most complex or complicated instrument to learn how to play.
Mm-hmm.
So that is definitely underrated. Overrated?
That was a good little choice right there. The brass French horn. Okay.
Yeah. Most overrated instrument. I don't know. I don't know that I would say an instrument can be overrated because to truly master an instrument takes such a lifetime of dedication.
Mm-hmm.
There's, a handful of people that have truly mastered an instrument. And if it's overrated, I mean,
sometimes
man, you got to be.
I'm a musician. I mean, I played the trumpet like from middle school to high school, but I kind of stopped. But I know enough. But sometimes I'm like, man, if they took the flutes away, would we notice? But then
But you
when they're
need it
by
for trap
themselves,
music.
yeah.
You need
When
to
they're
like,
by themselves, I'm like, yeah, okay, I see the flute, but I'm just like, what can be taken away that we would miss? Like, is the piccolo? Do we need the piccolo?
Everything adds. You need it for trap music. The baby will have his beats, and then you got the little piccolo in the background.
That is true. We need that for future and all of his.
And then Meg Thee Stallion played the flute.
Lizzo. Aunt Lizzo.
Lizzo.
Yeah, Lizzo. So, all right. So we're leaving on trap music. If you didn't know that this was a Black podcast, you know that now. So I appreciate you, Dr. Bradley. We'll let you off the hot seat for Randy's random questions. I know he wasn't expecting that, but thank you for participating.
Of course.
All right. Shout out all your media handles if you want to give them to the listeners.
Oh man, yeah. So Stephen Bradley, MD. You know what I learned about branding? I guess you're like, oh, use your name. So that's me, Stephen Bradley, MD, on Instagram as well as on Twitter. And then the Black Doctors Podcast is on Instagram. We have a website, www.theblackdoctorspodcast.com, and you can go there, check out our catalog of episodes. You can even leave a voice note or review for the show. And then my website is stephenbradleymd.com. And, you know, there I do some medical ethics stuff and consulting. If you want to see my random music, you can check out my Instagram, because every month of this year, I've challenged myself to put out an original piece, because I got a laptop full of stuff that I have finished. So every month I'm going to publish a little 60-second soundbite, and hopefully, you know, look back and see progress over the years. Maybe not. We'll see what happens. So, you know, it's going to be a little bit of everything. That's what's going on Stephen Bradley MD on Instagram.
Okay, that's what's up. I see you doing things outside the world of medicine. That keeps you sane.
Yes, sir.
As I sit here and do a medical podcast. What is wrong with me? What is wrong?
Oh man, I love, but like, isn't it like so rewarding? Because I learned so much from podcasting.
Yeah, that is true. That is true. It definitely makes me stay more educated, especially in medicine, but gives me something to do outside that keeps me kind of fulfilled.
Yeah.
Yeah. So thank you, Dr. Bradley. Appreciate you hopping on.
Dr. Randy, appreciate it.
All right.